Welcome back to the Love of the Law podcast. In this episode, we're joined by Andy Wildstein, partner at Berkowitz, Hanna, Amdur, and Wildstein, to discuss gastrointestinal medical malpractice. Andy explains the warning signs of GI bleeding, delayed colon cancer diagnosis, and the critical mistakes that can lead to life-threatening outcomes. He also shares practical advice on why patients should trust their instincts and advocate for themselves when something doesn't feel right. Let's dive in. All right, I'm here with my good friend Andy Wildstein, partner at Berkowitz, Hanna, Amdur, and Wildstein. Andy, how are you doing today?
Great, great. Thanks so much for having me. Looking forward to speaking with you today.
Of course, and it's great to have you back on the podcast. So let's get into it. Let's jump into the first question. What are the most common types of gastrointestinal medical malpractice cases that you see?
Sadly, we see quite a few gastrointestinal cases in the malpractice world. Largely in these cases, what we see is that the healthcare providers identify that something is wrong. They then fail to identify the source or severity of the condition, and then it progresses. And the areas where we see this most often, gastrointestinal bleeding, failures to diagnose colorectal cancers, there's bowel obstructions. We see it in cases of all sorts of inflammatory conditions of the GI system, like pancreatitis or diverticulitis, appendicitis, which a lot of people are familiar with, and then also infectious cases, infections in the gastrointestinal system that go on to develop into sepsis. And so, with each of these, in very, very different ways, of course, the healthcare providers often have all of the information or enough information to know that something's going on, that something's not right. And then, for whatever reason, they go down this wrong path where they don't take the steps that could have prevented it from getting to a really terrible and tragic situation.
So, I know one focus of yours is the gastrointestinal bleeding topic. So, what are the most common medical errors that lead to malpractice claims involving gastrointestinal bleeding, and where do providers most often miss opportunities to intervene?
Most often it's pretty clear that a patient is experiencing a gastrointestinal bleed. And where the problems arise is there is often then a failure to identify the specific source of the bleed and provide definitive treatment for the bleed. In that, a problem where the initial providers who identify the bleed fail to involve all of the different specialties that can treat a bleed. So, for example, I think, you hear gastrointestinal bleed, and what do you think? Oh, a gastroenterologist must treat this, of course. And that's true. And they're often the first line of treatment where you get a gastroenterologist, they do a procedure known as an endoscopy where they can literally put a camera down into the esophagus. They can see what's going on. Oftentimes they can identify a bleed, and through that same equipment, they're able to provide treatment. So if that's the case, great. Um, but sometimes it can just be that the bleeding is further downstream and the endoscopy can't get there to see it or to treat it. Or other times, there might be such brisk bleeding that they can't find the source. And that's where the gastroenterologist needs to make the determination as to whether or not they need to bring in some of the necessary other specialists who can treat gastrointestinal bleeds. And there's really two in particular that are most often called in. One is an interventional radiologist, and the other is a surgeon. The interventional radiologist is able to treat a bleed by going into the blood vessels and treating it from within. A surgeon is able to go into, whatever portion of the GI tract and provide some sort of, hopefully definitive treatment. And so, I just had a case recently where, a GI doctor appropriately identifies a bleed and had a real hard time identifying exactly where the bleed was and kind of took a best shot at trying to treat it and was able to stop the bleeding for what was a very, very short period of time and really should have known better, should have known that he was not providing definitive treatment. And at that point of time, should have said, hey, I've got a GI bleed. It looks like I've stabilized it for right now, but I need to get interventional radiology and I need to get surgery in so that they can determine whether or not either of them or both of them are the appropriate providers to provide life saving treatment. And instead, what this gastroenterologist did was he was like, hey, good job. I did it. And 24 hours later, the patient rebled. And by that point in time, the bleed was so significant that neither surgery nor interventional radiology was able to provide a life-saving treatment. And in these cases, you don't need to be a doctor to know that bleeding is bad. It's so important that if definitive treatment can be provided in a timely way before someone is like an extremist, that it be done. And so this is a case. It's a tragic, tragic case of somebody in his 50s who passed away because the gastroenterologist didn't bring in the other members of the team who could have been there within 30 minutes at the time of a consult request. That's a big part of what we see in these cases. They know there's a bleed. They may have some trouble identifying where it is. So they're unable to treat the source, and the proper teammates aren't brought in. And each and every one of those steps, most often, are able to provide definitive care that can save someone's life.
Now, in gastrointestinal, or sometimes called GI bleeding cases, how do plaintiff attorneys establish that delays in recognizing, diagnosing, or treating the bleed directly contributed to a patient's injury or death?
So all of the elements that we need to prove in a case, we have to do so using expert witnesses. In gastrointestinal cases, I mean, there's a variety of different experts we'll use, but obviously gastroenterologists, sometimes hematologists who are specialists in blood. Similarly, it can be surgeons or interventional radiologists, depending on who are the types of providers who are going to provide the definitive treatment. Because you'd want them to be able to say, had I gotten in at such and such period of time, more likely than not, I would have been able to save this person. What's interesting in a bleeding case is that, in terms of proving how long someone could be saved, it's often a case of just looking at their clinical picture. Because if a patient is doing relatively well, they might be uncomfortable, they might have labs that indicate that they're having some slow bleeding or they're not responding to treatment. Typically, up until the time that they have the catastrophic bleed event, they could have been saved. And I had another case that recently resolved where it was a patient who had a bleed event and then seemed to stabilize. What the providers were doing was they kept giving him blood transfusions. And so what would happen is his blood was kind of staying, when you looked at the labs, kind of at a stable level. But it was, in fact, that was wrong. It was staying stable because he was bleeding, and then they would pump him up with blood, but he continued bleeding. And so the fact that he was stable was not a reassuring sign. It should have been going up and up. And then at the end, and of course it was in the middle of the night when there aren't all the providers actually there in the hospital, he suddenly starts vomiting copious amounts of blood. And at that point in time, we now know that he is having this catastrophic event and he's losing blood quicker than they can give him blood product. And his heart and his body, his organs just can't sustain. And so typically up until that catastrophic moment, treatment should be provided that gives a better opportunity for a patient to stop that bleeding. If we can prove that if any of these providers, whether it be a gastroenterologist, a surgeon, interventional radiologist, could have gotten a patient in at some point in time before that moment, we can make a very good argument that they were salvageable right up until the very, very end. And so typically in these cases, what you see is there's kind of a continuum of claims of negligence because when the patient first comes in and they're exhibiting signs of bleeding, obviously that's a point in time. It's a decision point. Should the doctor have provided some kind of treatment then, or should he have called in a consult who could have provided definitive treatment? Okay, well, they didn't do it then, so that's a problem. The next day, when the labs aren't improving, well, there's another opportunity, but he's still salvageable, or she. And then again, day 3, wow, we've got a drop in the labs. They're showing that he's losing blood, but, the patient's not doing terribly, so they're like, let's wait. And what happens is each of those moments, first of all, they're draining a person's reserves, so their ability to sort of fight back or deal with an insult to the body. But it's also yet another opportunity to have taken a step to save this person. And then what happens is you have this catastrophic, often completely preventable but totally predictable event where somebody has this complete bleed out event. And at that point in time, all of the treatment is harder to provide. When somebody's bleeding, their vessels are collapsing. So the interventional radiologist can't get access to try and stop the blood source or they can't find it. The surgeon, they're too dangerous to go in under anesthesia. They can't perform a surgery that would save that person's life. Or the endoscopist, it may just be that if the source of the bleed is out of reach, they can't do anything. Time and time again, we sit with families and, we do these investigations and we talk with all of these different experts who explain all of these different opportunities. And you can imagine just the devastation of learning that, it wasn't just that somebody came in and they were bleeding and they passed away a half an hour later. They were here, they were admitted for a week, and there were so many different opportunities to do the right thing, and they didn't. And we do what we can to try to provide them, support and closure. But at the end of the day, there's nothing that we can do that equals their loved one should still be alive.
Wow, I can't even imagine being in that position that you and the family have to be in during those moments trying to find answers. And thank you so much for giving us that perspective and sharing that story. Now, for my next question, I want to pivot over to colon cancer litigation. What are the biggest legal issues in delayed colon cancer diagnosis cases?
In the colon cancer cases, we see that it's often, again, it's not a matter of a failure to diagnose once they get sent over for the colonoscopy. It's more often a failure to have implemented the appropriate screening for a patient. A lot of these cases we'll see not in the GI doc's office, but in the internal medicine or the PCP's office, where there's a patient who, for years is coming in and they've got some GI complaints and your PCP is thinking, he's got, GI issues just like a lot of people and doesn't really think it warrants work by a gastroenterologist. And so what happens though is eventually something becomes much more problematic, whether there's bleeding or it could be, someone's having a hard time with bowel movements or whatever the case may be. And they finally do get to the gastroenterologist. They get that colonoscopy and they're found to have an advanced colorectal cancer. And so, in that respect, from a standard of care standpoint, it seems like a fairly straightforward argument that we can make saying, hey, the PCP should have sent this patient off for screening much sooner, for a variety of different reasons. Trickier part in those kinds of cancer cases is on the causation side of things. And what I mean by that is we have to prove not just that the doctor did something wrong, but we have to prove that what they did wrong was the cause of the harm, was a substantial factor. What the defendants will often do in those kinds of cases to try and defeat our case on causation is to say, hey, look, you're right. Maybe we should have referred him sooner. However, this cancer was the kind of cancer that had been advanced and was metastatic for a very long period of time. So even if we had sent this patient for a colonoscopy, let's say a year earlier, the outcome would have been the same. He still would have had the same level of cancer. He would have required the same level of treatment, or it was a cancer that was not going to be curable. And so often in those cases, it becomes a battle, not so much on standard of care, though that's always an issue, but it becomes a battle of oncology experts. So we get GI oncologists who will say, based on what we were able to tell from the specific nature of this particular cancer, this was a cancer that had been observable for years and years and had not yet metastasized until sometime much, much closer to the ultimate diagnosis. And in those kinds of cases, as the plaintiff, we're able to prove our case. But if an expert were to come in and say, hey, look, this cancer was a super aggressive cancer. It developed very quickly and very recently. And those GI symptoms the patient was complaining of for years, that really was something else altogether. Then it's a tougher case for us. And so those are the challenges. And so that's why it's really, really important when we investigate a case that we get all of the appropriate experts who can comment on this and, based on literature, based on experience, come in and say with a straight face in a way that will be meaningful to a jury, this is a case where this is a delayed diagnosis and where that delay made a difference in terms of this person's outcome.
What defenses are most commonly raised by hospitals and GI physicians?
So causation is a big one because, for example, if we go back to the bleeding cases, oftentimes what we'll hear is there was no way to save this patient. There was just no way. And that's an easier defense if it's the dynamic where a patient presents with a bleed and there was a very short period of time before they passed away. It's a much less effective defense when, a patient's been sitting in the hospital for a week and there were all of these opportunities like we had discussed a bit earlier. Another defense that we see a lot is that it was as a result of the patient's own bad health or choices. Frankly, we see it where there are claims of a patient having, had an alcohol problem, for example. And there are associated GI conditions associated with alcohol use or with poor eating habits or poor nutrition or whatever the case may be. And while that's true that there are these associations, it doesn't change the fact that somebody coming in who needs care should be afforded appropriate care. And look, if it turns out that somebody's prior medical history has made it so that their likelihood of surviving was very poor, maybe it's not a malpractice case that we can bring. However, and we do this very frequently where we have patients with, people come with their history. They show up for care with whoever they are, and they can still be provided appropriate treatment and saved. We just know that in those cases, the defendants are going to say, hey, he couldn't have been saved. He was an alcoholic for 20 years. He did this to himself. And in those kinds of cases, it's our job to make sure that we get appropriate experts who can say, not the case. This was somebody who was able to be saved. And, we try to turn that around like, how dare you? That's an unfair attempt at trying to sort of draw on people's biases to feed an appropriate claim.
As we're talking about GI, I'm going to throw out another one that is a common term, AI. Is AI likely to reduce missed GI diagnosis or create new liability risks?
Monty, I think the answer to that is yes to both. I try to be optimistic about the benefits of AI, where so many of the GI cases are based on assessment of labs and imaging studies. And so, if you can add to the human element an AI level of assessment of those results to help identify potential problems, I think that could potentially translate into, frankly, better care, which would translate into fewer potential claims for malpractice. So, in that respect, I think AI can be a benefit both from a care standpoint and an outcome standpoint. What I worry about with AI is that it becomes a crutch. And I mean, you see it with like, kids in school now where they're just like having their term papers written by AI, and suddenly there's stuff in there that's not so accurate. And the worry is if somebody begin relying on AI interpretations of imaging studies rather than using their own sort of common sense judgment discretion as a radiologist, that there could be misses. And so I do worry about that. And I think that it's something we're certainly cognizant of as we investigate claims and what types of technology are being utilized to perform the assessments at these hospitals. And a lot of times there are people off site and, doing interpretations of imaging. And I could see that very soon down the road becoming not just off-site physicians, but off-site AI tools being utilized. And so that could be problematic. The jury's out. We'll have to wait and see, but it's a worry.
And my final question before we sign off, if patients could take away one lesson about advocating for themselves when experiencing serious GI symptoms, what would it be?
You have to have a level of comfort advocating for yourself. So many people, whether it be certain generations or your own personality, have a level of discomfort with the idea when they feel something is wrong. Well, hey, I'm not the doctor. Who am I to challenge whether the care that's being provided is appropriate? And I think it's really important, especially in the current state of medicine, where there are so many different providers who are seeing you, and there might not be continuity of care, to say, hey, my condition is different from what it was yesterday. I am worried about this. I think I need to be worked up, as opposed to just sitting there and waiting till tomorrow and just assuming that they're all doing the right thing. I'm very confident that most healthcare providers got into this work because they want to help people, but there are just lapses, systemic lapses, individual lapses that we see all the time. And so often, what ends up happening, as I was describing earlier, is something goes wrong in the middle of the night when the A team is not available to provide care for you. And at that point in time, it's too late. And please take away from this having a level of comfort advocating for yourself, making sure that the care that you're being provided is what needs to be provided.
Andy Wildstein, partner at Berkowitz, Hanna, Amdur, and Wildstein, thank you so much for your time today.
Hey, my pleasure. It's good talking with you, Monty.